2.
Okay, welcome everybody. As you all know, my name is Norah Eggy, and I have spent this semester researching U.S. health policy with a focus in the quality of our U.S. healthcare system. So I've got a PowerPoint that I'll present to you guys. And then at the end, we can have you ask questions. You can put them in the chat. You can raise your hand and ask them out loud. But yeah, let's go ahead and get started. And people can always join in later. And if everybody could have their cameras off and their mics muted, that would be great. Okay. Can everybody see that?
Yes, it's very clear.
Okay, so welcome to my presentation, The Price of Health, where we are going to take a deep dive into healthcare quality in the US and what we can do to improve it. So we need to start by defining what quality is. And quality is defined as the degree to which health services increase the likelihood of a desired outcome consistent with current professional knowledge. And we measure quality using the Donabedian method. And there are 3 equal parts to the Donabedian method, which are structure, process, and outcome. And structure has to do with the physical aspect of medicine. It's, do you have enough nurses? Do you have enough supplies? Do you have the latest technology? Do you have clean facilities? Do they have enough beds to house patients? That kind of stuff. And then you go into processes, and there's both technical and interpersonal processes. And technical processes deals with, is the care safe? Is the physician introducing any harm in the process of their treatment? Is it timely? Is it efficient? For a long time, doctors, when they were diagnosing their patients, would kind of throw tests and diagnoses at a wall until something stuck in a process called shotgunning. And in doing so, they'd rack up thousands of dollars in tests without devising a clear conclusion of what their goal was. They were just throwing stuff at a wall. So part of processes is how efficient something is. And then you have interpersonal processes, and that has to do with bioethics. And if any of you were with me last semester, you know that I talked about that a bit. But that just has to do with the relationship between doctor and patient. Are they respectful of a patient's language, culture, religion, just that kind of stuff. And then obviously you have outcomes, which is morbidity, mortality. Was the procedure successful? And just stuff like that. So after this method came out, researcher Beth McGlynn went across the country surveying patients, and what she found is that 45% of surveyed patients did not feel they received treatment consistent with the Donabedian method. They did not feel that their care met these quality standards. So this was a very statistics-heavy course. And I'm going to be reading out a lot of statistics to you today, but what I'm hoping you can see is how these statistics tell a story, what they show about our healthcare system. So only a third of elderly people received their timely pneumococcal vaccines. Only half of hypertensives have their blood pressure controlled. And 18,000 people die each year because of a failure to provide care for acute myocardial infarction. And these are very simple things to treat. These are very standard things that should be happening on a consistent basis. But as you can see, it's not happening for a very large chunk of our population. And what this is telling us is, while when it comes to big, fancy, once in a lifetime, complicated, unique type procedures and medical cases, the US shows up and shows out. We are excellent. But when it comes to the standard of care, when it comes to the basics that the majority of our population needs, we are not there. We are falling behind, and we are not meeting these basic medical needs of our patients. And then you have to look at the value of US healthcare. So we spend $3,000 more on healthcare per capita than the next leading country. So we spend about $8,000 per capita on health spending. Our health spending has grown 17.7% above all other developed nations since 1980. So in 1980, we and the other developed nations all sat at the same place. And since then, these other developed nations have grown linearly in their health spending, while we have grown exponentially. And we've just grown that much more in our spending. We obviously spend way above average on health spending, but we spend way below average on welfare spending. So that's things like education, food security, affordable housing, affordable childcare. And the problem is health spending, things like Medicare and Medicaid, are often considered welfare spending. So they are lumped in. These two metrics are lumped in as one welfare spending. So while we are dramatic outliers on each individual metric when they are combined, which they often are, we're able to hide in the middle and not draw a lot of attention to how much disparity in our money allocation. So since 1999, worker earnings have risen 50% and inflation has risen 40%, which is good. That's great. In the same light, health insurance premiums have risen 182%, and worker contribution to those premiums have risen 192%. So the price of health insurance is rising at almost a quadruple rate than workers are earning money. And employers are not covering their employees' healthcare anymore. Workers are starting to have to buy this for themselves, and it's becoming extremely expensive and unattainable. So we're obviously paying a lot of money for our healthcare. So it would seem that we should have the best healthcare in the world. If we're spending this much, we should be getting back that same quality of healthcare. Well, 32% of adults experience lab or medication errors. And this is significant because I learned this fact in the beginning of the course, but a few weeks later, I learned a similar fact. We were talking about the strengths and weaknesses in US healthcare. And what the course identified as one of the US's strongest aspects of our healthcare system was our drug prescription and medication. So our ability to prescribe drugs and to medicate people is what we consider to be one of our strongest fields, and yet a third of people are still experiencing error. We exceed all other developed nations in infant deaths by 1.6 deaths per thousand, and we are ranked 26th in the world for life expectancy. So we're paying all this money, and these statistics are showing us that we're not getting a lot back. We're not getting a lot out of it. And then we have to talk about how we finance healthcare. So a consistent theme in this course was that how you pay for your healthcare has a huge impact on the quality of your healthcare, and a lot of that has to do with the psychology of the doctors being paid and how the money moves through the system, but it does have a very big impact. And we obviously, the US has a private health insurance system, a multi-payer system. And there are two main ways of paying for health care, which is pay per performance and fee for service. And for a long time, payment was indifferent to quality, and that had to do with fee for service. So it didn't matter how effective the treatment you got was. This goes back to the overuse I was talking about earlier. Doctors could prescribe however many tests they wanted, could run with as many diagnoses as they wanted, and you had to pay for it. It didn't matter if it was effective or efficient or concise or intentional, you paid for it. And then we started moving more towards a pay per performance system where physicians were rewarded more based on quality, and hospitals would get charged fines for high rates of readmission. But we still live in a capitalist society, and under capitalism, healthcare has become extremely monetized. So you can implement a pay per performance system as much as you want, but we are still our quality is still heavily dependent on finances, how much money you have, and how that money is moved through a system. There are three types of private insurance markets. There is large, small, and individual markets. And for each one of those markets, there are about 2,000 insurance companies. And for each of those 2,000 companies, one of them will have over half the population insured, which is telling us that there is such a huge monopoly in health insurance. These companies have no competition. And if you open a dictionary and you look up the definition of middleman, it'll show you private health insurance. Because what we found out is that patients and physicians are fairly indifferent to the price of their medical care, because as patients most often don't pay for care themselves, their insurance company does it. And physicians aren't directly rewarded for their care. They're paid by the hospital. They're just there to do their job. So these two parties are fairly indifferent to how healthcare is priced, which leaves room for these health insurance companies to set the prices for healthcare. And when these companies have a monopoly and are not competing with other companies, that gives you the perfect recipe for them to charge whatever they want for healthcare, and that can be very dangerous. And then obviously during the Obama administration, there was the implementation of the Affordable Care Act, which started the movement towards universal health care. And the Affordable Care Act did so many great things, and it'd take me far too long to get into the specifics of that. But one thing I thought was important to note, something that I didn't realize before I started this course, is that the Affordable Care Act actually pays for itself. I think a lot of times in the news, you hear negative connotations about it, about how much it's costing the government, how it's barely being held together. But it pays for itself, because Title I and Title II, the most expensive titles, cost about $900 billion together. And then Title III and Title IX then make up those $900 billion. So I just thought that was something cool to note. But between the poor value and the poor quality of our healthcare system, we're obviously not doing too great. So how do we fix it? What can we do to improve the quality of our healthcare system, to improve the value, so that we're better taking care of our patients? And this first solution is a mantra that I've been peddling this whole year, which is health is more humanity than it is a science, and looking into the value of human collaboration and human connection in medicine. So our knowledge of medicine has expanded far beyond human capability. You can't expect a nurse or a physician to remember the exact name and purpose of the 6,000 different drugs on the market. And more surgeries are actually performed annually than babies are born. And so between these two, it's kind of a recipe for high death rates and negative growth, because human error happens. We have more knowledge than we can be capable of retaining. And when we put that knowledge into practice via surgeries so often that it's more than babies are born, we have very high death rates. So to combat these human errors, physicians began to use checklists. So you'd say, do we have this, and this tools before we get started? Is the patient on this, and this medication? And what they found out is that obviously surgery is not procedural. You have to think on your feet, complications happen, each patient is different. So these checklists weren't super effective. So they started orienting the checklist towards teamwork, which meant introducing yourself to the other healthcare workers in the room, discussing the goals of the operation, who the patient was. And something that really shocked me and really resonated with me is that when you do something as simple as introducing yourself to the person next to you, complication rates fell from 11 to 7%, and death rates were cut in half from 1.5% to 0.8%. And I think that really just showcases the value of connecting with other human beings and working with the people around you for the benefit of your patient. Obviously, healthcare and hospitals are very autocratic and very hierarchical systems. Newer people don't have a whole lot of respect. People who are have been in training for less time often feel that they don't have as much respect from their peers, that their voice doesn't count as much. And there is so much pressure on them as an individual to be perfect. So when things like error happen, they don't feel they can speak out about it for fear of losing their job, for being undermined. So these hierarchies create a barrier between physicians, and it makes it very hard for them to communicate effectively with each other. Because, like I said, human error is inevitable, but if people don't feel they can speak out about it, people die. It's also about promoting patient involvement in care. It's not always about prescribing care for your patient, but prescribing care with them. There's a health literacy program at Iowa Health Services that is redesigning the consenting process so that the patient teaches back the procedure to their doctor. And it's a lot of it is about strengthening the relationship between doctor and patient, creating a sense of respect and equal sharing of responsibility, making sure that the patient understands what is happening to them and why, so that they feel safer, and just building those human connections. So what is our next solution? Universal healthcare. Universal healthcare is both important and attainable. Currently, there are more than 37,977,000 uninsured Americans who, because they are uninsured, are at a 40% higher risk of mortality. Universal coverage removes the barriers to primary and preventative care. And primary and preventative care are very important to improving quality in the US because there's a large dependency on hospitals and emergency room care. And what happens is these systems get overwhelmed with people who either don't need to be there, but they don't think they have any other option, or they're going there for an issue that could have been treated with primary care, but it's already too late. So primary care helps catch things early, helps treat things early, and raises national health by a very significant amount. And universal coverage removes those barriers because if you're uninsured or you have poor insurance and you go into your primary care physician's office and you say, I need a physical or I want to book a checkup, and you don't have the money to pay for it, they're going to turn you away. But if you go into an emergency room coughing up blood, they can't turn you away. It doesn't matter what insurance you have. It's an emergent situation. But at that point, it's already gotten to the point where the issue has manifested and you're coughing up blood, and it can be too late at that point. So under a single payer system, Canada allocates 6.2% per capita to preventative medicine, and single payer meaning universal health care. The US, under a multi-payer system, allocates 2.8% per capita, and as a result, have a 28% higher rate of fatal cardiovascular disease. So this goes back to the idea that if we invest more in preventative medicine and primary care, we can catch issues early, help treat them for people, and raise our level of national health. Private insurance actually directly contributes to the opioid crisis in America. So the cost of opioid versus non-opioid drugs is very different. Opioids are a lot cheaper than, say, physical therapy or non-opioid drugs. So if somebody breaks their leg and needs time to recover, if they have poor or no insurance, they're going to be turned towards opioid drugs, which can get them addicted and ruin their lives, the lives of their family members. And in a cruel stroke of irony, their lack of insurance or poor insurance also means that they aren't going to be able to pay for rehab either. One thing that really, really surprised me is that when the legislation on the advertisement of opioid drugs was lifted, drug reps who sold opioid drugs went around and specifically targeted physicians in training to sell their opioids to, because they knew that these physicians wouldn't have the experience to know how detrimental opioid drugs could be to their patients. Universal healthcare also boosts the economy, specifically by $73.7 billion annually. You're not a productive person if you're at home sick all the time. And universal healthcare also improves doctor-patient relationships. Private insurance a lot of times pressures physicians to see people at an assembly line rate for even 15 minutes at a time. So even people who do have the ability to access primary and preventative care are only seeing their doctor for 15 minutes at a time in very, very short intervals. So there was a doctor in the Mississippi Delta, Dr. Mary O'Brien, who had a diabetic patient who was struggling with very, very high levels of sodium that was proving to be very dangerous for her. And she had been to 5 different doctors who had all prescribed her 5 different medications, expensive medications. And nothing was working, nothing was helping. And when Dr. O'Brien took the time to sit down with her and talk about her lifestyle and what her life was like, she found out that her diet consisted of primarily canned foods, very high sodium foods, and that was the source of her issue. And she got her set up with a dietitian, took her off these 5 different medications she was taking, and was able to fix the issue. And it seems like a very simple solution. It seems like a very obvious solution. And quite frankly, it is. But it took 6 doctors to diagnose this issue. So when we implement universal health care, there is a lot more opportunities for doctors to build closer relationships with their patients, to see them for more time out of the day and really discuss what their lifestyle is like, and not just what drug can we throw at you to fix the issue. How can we trace the root of this problem and fix it? And lastly, quality doesn't mean anything if people don't have access to it. We could fix all these problems and have the best quality, best value healthcare system in the world. And if the majority of the population can't access it, it doesn't mean anything. And that's why universal healthcare is so important in the road to fixing quality. And that is it. Thank you all for diligently paying attention. And if people would like to start asking questions, they can raise their hand, type in the chat, anything like that, and I'll be happy to answer them.
Which one would you prefer? Either way?
Yeah, either way is fine. If people can ask questions by turning on their mics, that might be easier. But I guess it's whatever people are comfortable with.
Okay, and I know you've put this in your blog, so I'll ask my question then. So you've outlined very specifically that it's not a cost issue, and it obviously is pro-human, right? It helps patients. Why do you think we can't get this passed? I know that's a huge leading question, but
it's the political culture. We are very divided right now. And the thing is, universal healthcare isn't a partisan issue. It's not. one group isn't for or against it because it benefits everybody. The only reason it's not happening is because our political culture is so divided, and the monopoly power of these private health insurance companies or the lobby power of these private health insurance companies and the money they have is so significant that they've been able to bankroll politicians into being against it. It shouldn't be a partisan issue. It should be a very easy thing to implement, but it's just not because we're so divided, and the power these companies hold is holding our government hostage.
Thank you. What was the year again? I can go back on the slides, but what was the year again when we were pretty much all even? Oh, and I see you have a hand raised, but can't remember what year you said when we were all
1980.
even. Oof.
Mr. Pattinson. Did you have a question? Okay. Kale, did you have a question?
Yeah. So I know you've said that for America, money is not an issue in terms of healthcare. I was just wondering if the per capita, the money that we have per population, if that's still the greatest or still very large, or if compared to other countries, our per capita is less. I don't know if it has any effect, but having a lot of money and a lot of population might kind of negate the two things. I don't know if you know.
I think what I'm interpreting from your question, yeah. So we're spending a lot of money per capita. So it's not just that we're spending a lot of money because we have a high population. We're spending a lot of money per person more than any other country. It's not about how many people that we have. It's still very much just that we're spending that much more money proportionally.
Okay, that makes sense. Thank you.
This is Brent Pattison. Can you hear me now?
Yes, we can.
Great. So my question was, is there evidence of higher quality in delivery of medical services under our current publicly funded models? So Medicare, Medicaid, when you compare the quality of medical services provided under those systems, how does it compare with quality under private insurance?
Well, there was actually a portion of my presentation that I had to cut out for timing's sake, but it had to do with health information technology, and how that can improve quality care. And it's not very widely implemented in the US because it is kind of an expensive system. But the majority of people who had the systems that had it implemented was the Veterans Affairs Medical Center, which is a public health care facility. And they were showing, because of this health information technology system that was able to be implemented because they had a public health care system, they were showing much higher levels of quality care. Doctors were able to prescribe things a lot more efficiently. People were able to keep track of medication better. And just a lot of the statistics that I talked about were improved. I don't know if that exactly answers your question, but. Miss Vald.
Hi, Nora. This was really, really interesting. I'm curious what inspired you to choose this topic. So you can comment on that if you'd like to. But my question is related to the research and again on the quality topic. Did your research share how or if medical schools are addressing the quality or how they're addressing the quality issue and or maybe associations that doctors and nurses are in once they're in practice?
Yeah, so I got interested in this topic because I want to be a doctor when I grow up. But last semester I took a course in bioethics, which kind of directed me into this course, and I just thought it was super interesting. I think health policy is a complicated issue that I myself don't fully understand, and I think it's important for doctors to know about. But to answer your question, um, I don't know specifically if medical schools are teaching health policy, but what I know is that there is a movement towards medical schools teaching more bioethics, which, as I talked about in my presentation, does have a deep connection with improving healthcare quality, because bioethics deals with um, implementing human connection into medicine, which can be very beneficial to quality. So I don't know if health policy per se is becoming a focus in medical school, but I know bioethics is, and they are very interconnected, and have a big impact on quality improvement and human connection.
Very good. Thank you.
Is that it for questions? Does anybody else have anything they want to comment on or ask?
So if you had to give, and I think I might have put this in your blog. So if you had to give, you have to give one sentence, because they're probably not going to listen to you longer than that. One sentence, maybe two, to any of your elected officials in Washington on why this should be passed. Give me your shortest sentence that they would listen to. Go.
Medicine and healthcare is a humanitarian issue. It's not a scientific one. And our policy needs to reflect the universal right for a human being to have access to healthcare.
Ooh, nice. Send that to them today. No, I'm kidding.
Well, I might finally email Mitt Romney with my grievances about universal health care, but that is a story for another time.
Or they can read it in your blog.
Yes, I do talk about that in my blog. Alrighty, well, if there are no more questions.
I will stop recording now then.
Okay, thank you all so much for coming. This was such